So the final topic is going to be on myelopathy from multilevel stenosis with kyphosis. I'm Jay Turner from Phoenix, and we have two more leaders in our field: Dr. Osger from Hoag, the director of the Hoag Spine Center, and Dr. Rhodes, professor at Emory, and former chair of the section. And so to set the stage, we've got a case. So this is a 40-year-old female, 6 months of progressive myelopathic symptoms, myelopathic on exam, hyperreflexic, weak hand grip, with this MRI and a set of x-rays, the flexion extension x-rays, no dynamic instability, reduction of the kyphosis and extension, and level by level, C3-4, C4-5, 5-6, and 6-7. And so we're going to discuss surgical treatments. First, we're going to hear from Dr. Osger, who's going to convince us why we should be doing standalone multi-level ACDFs to treat this pathology. Dr. Osger.
Good afternoon, everyone. Thanks to the organizing committee, the scientific committee, for having me here today. It's a real honor to be here in front of all of you and to be here for the Cahill debates. Thank you very much. So the first thing I'll start out with is just say, if you all went back to work and next week was full of ACDFs, who would be thrilled with that? I, for sure. I would love to do ACDFs every day. In fact, a one-level ACDF is one of the best operations, I think, out there. And moving forward, I think even the case that was just demonstrated, love to do a two-level standalone ACDF for that case. Patient's going to do great. Patient's going to be really, really happy. Here are my disclosures. And so I'm talking about the anterior standalone device as being the next big thing. And I truly do believe that. This isn't one of those times where you're assigned a topic and then you got to try to make sense of it. I do believe it. So this is sort of the device that we're talking about. This is a zero profile standalone. One of the confusions in the literature is that it goes by many names. I've seen it listed as a hybrid device. I've seen it as ZP. I've seen it as zero profile, and of course, standalone. There are many iterations of it. This is one form of it. And basically, it's sort of an integrated inner body with sort of a mini plate and screws for fixation. I think it's a great iteration of our ACDF operation. ACDF is, as many have said already, is a great case. Patients do really well. Patients are happy. And where do you go from there? How do you make it even better? And I think the zero profile element of it is one of those ways that it's gotten better. When you do a case, it's very easy to go and do your discectomy, put the inner body cage in, and I think this part that's frustrating at times, especially a 3 or 4 level, is putting a big plate on. I think the worst part about a multi-level is really the plate. So if you really put in the inner body device and throw in some screws, it's pretty quick and easy. So the first question I would say is anterior better than posterior when we're looking at cervical myelopathy? In general, I would say I would any day want to go anterior versus posterior. One is just selfishly. I think for me, as a surgeon, I'd rather go anterior whenever I can. I think it's an easier operation, better planes, easier positioning, and most importantly, less headaches, phone calls from the patient to my PA or to myself. So, because I think a posterior cervical is going to be a lot more painful from the dissection of the muscles. Here's just one article talking about looking ACDF versus laminoplasty. Of course, I know there are a lot of fans here of laminoplasty versus laminectomy, but I would say I'm a bigger fan of anterior versus either of those operations. And what did this study show? It showed that there's no difference in the JOA score, the operative time, or complications, but it did suggest that there were other benefits in terms of blood loss and maintaining lordosis, as well achieving that lordotic curvature when you have a good inner body anteriorly, especially multi-level. Second question is standalone ACDF or this hybrid an option for multi-level cervical myelopathy? And so another article would demonstrate here that looking at 3 or 4 level ACDF with a standalone device, and they basically showed that, again, all the patients did well. However, the patients that had the self-locking, zero-profile type device, short segment, tend to have reduced intraoperative injury, restore cervical lordosis, and improve function overall as well. So again, this demonstrates that I think, from my own experience as well, that a multi-level standalone is a good option. Is standalone ACDF hybrid a better option than traditional ACDF? So I think as we look at this, there's an article that basically also demonstrated this ACDF versus ACDHF. Again, the H is the hybrid or the standalone that they're talking about. And in particular, in these long segment device, this also showed that it's effective in restoring lordosis in myelopathy cases, but the hybrid surgery minimizes intraoperative injury, postoperative dysphagia, and so on. So I think the only thing that kind of bothers us about ACDF is really the patients. We know everyone's going to get a little bit of dysphagia or discomfort swallowing, but that's going to go away. But when you put a big old plate on, that's a little bit more of a headache that you might get, especially if you're going up to C3-4, a thin female, and you may also get Horner syndrome, damage to the recurrent laryngeal nerve. What are sort of the takeaways I get? Well, a meta-analysis shows that ACDF is preferred to laminoplasty. Short segment standalone ACDF restores lordosis, decreased intraoperative injury, decreased dysphagia, decreased postoperative complications. My own personal experience with 290 patients and over 700 levels, none of them had complications or infections. We did have a readmission. It was for a dysphagia. Patient got some steroids and got better. But I really feel in the properly selected case that a multi-level standalone is a great case. Here's an example of 1, 2, 3, and 4 levels. Good interbody height, good lordosis. And to me, again, what I think of it as, it's like doing multiple one-level ACDFs, which again is a great day in the OR for me. I'm happy with that. Here's a more complex case that we had to deal with, kyphotic degenerative. So this is worse than the demonstrated case. And what I thought here is just full disclosure to my patient. I don't know if I'm going to get away with a multi-level standalone, to be honest, right? We take, as Zoe was saying earlier, we take every case by case individual. And so I told this patient, I'm going to do 4 one-level anteriors, see what we got, what the bone quality looks like. We can get an image, we can see how the patient's doing, and move on. And that patient did great with just the standalone. Now, this patient I thought would have done fine anteriorly with just standalone, so I did 4-level anterior, and you can see it has disc ossify complex cord compression. I thought I'd get away with it. When I went in, I found that she had actually a little bit of soft bone, and when I got an MR, I got good decompression, but not as much as I had expected, and so I did do a front back on her. The end result is basically, I believe, anterior is better than posterior. The pathology is anterior, so why not go anterior for the decompression? It's better for the surgeon, it's better for the patient. Standalone ACDF better than traditional ACDF. Again, my thought is that it's like doing multiple single levels and no big long plate to struggle with. That's the worst part, in my opinion, with a multi-level ACDF is dealing with the plate. And then many of us have seen an X-ray a year later and you get subsidence and the cage is migrating or tilting a little bit. And last, worst case scenario, you can always stage it. You can always start with the anterior, see how the patient does, and you can come back and do more if you had to. Thank you.
Well done. All right, so now we're here from Dr. Rhodes, who's going to explain why all that is nonsense and it's a terrible idea. Thanks.
So I'd like to thank the organizers for the opportunity to participate. And just a few brief words about Dave Cahill. I had the privilege of knowing him, and I think many people here did. Dave had a very sly, cynical sense of humor. He was a real critical thinker. He was never afraid to tell you what was on his mind or what he thought of your work or someone else's work. And I just think it's been perfect all these years that we honor him, with this set of debates in his name. And when you get assigned, I've done this before, and when you get assigned topics. Sometimes it's pretty challenging. You can see from my list, I've had some challenging stances to have to defend over the years, but I'd like to thank the organizers for this one today, which I think is a winner. I don't have any real current or active arrangements with companies. I think it's pretty obvious there's a huge difference in age between myself and my opponent, and he's published on this topic. So I think I let Ron Reagan kind of speak for myself.
And I want you to know that also I will not make an issue of campaign at any technical issue or political purposes. My honest youth and experience.
So I was expecting and did hear a little bit from my opponent that he was going to talk about it in terms of criticizing plate fixation with ACDF. He would mention dysphagia, soft tissue damage, higher incidence of adjacent segment degeneration with plates compared to these standalone cages. But the facts are pretty simple. There's a higher incidence of non-union with the cages that's standalone. There's a higher incidence of subsidence, and the latter leads to lordosis, loss of lordosis or frank kyphosis, and therefore subsequent adjacent level degeneration. This is a retrospective study of 81 patients, single level, either a peak cage that stood alone or a peak cage with a plate. The clinical outcomes were actually very similar, but the radiographic results were not. There was a much higher incidence of subsidence in the standalone cervical cage group compared to a plated ACDF, and the segmental kyphosis was much higher in the standalone cage group compared with the ACDF, and they listed numerous publications that cited the same kind of findings. This was a study of 4-level ACDFs for both myelopathy and radiculopathy, and there was basically the results show that 1 in 5 patients had at least one level of non-union. They also noted the sinking or subsidence of the cages. Interestingly, though, the neck pain indices and lordosis remain improved compared to pre-op. This is another retrospective study, standalone cervical cages versus anterior plate and cage in 2-level cervical anterior fusion constructs. They measured subsidence, global and regional lordosis, time to fusion, clinical outcomes. Adjacent segment degeneration and dysphagia were not studied, and they had about a 2-year follow-up. And they used pretty standard Cobb angle measurements, and what they described as or defined as subsidence was just a change in the length of greater than 6 millimeters of the distance measuring from the top end plate at the top of the construct to the inferior end plate. And what they found is that the plated group had a quicker fusion. The plated group had less subsidence. 80% of the plated ACDF patients had reported excellent clinical outcomes compared to 53% of the standalone cages. But the authors admitted that the study was too short to address really the effects on adjacent segment degeneration. This is one of the rare prospective studies, Zavros and others. They published a study on standalone cage versus anterior plating for both 1 and 2 level ACDFs. And they used, in terms of what went into the cage, they described just using some bone from a suction trap and a commercially available biological peptide that was designed to promote fusion. Their primary endpoints were improved patient-reported outcomes, construct integrity, cervical alignment, successful fusion, and need for revision, and there was a minimum 1-year follow-up. And there were no differences in rates of fusion or changes in disc space height or subsidence or lordosis parameters. There was a greater incidence of transient dysphagia in the plated patients at 6 weeks and 6 months, but at 1 year, it all evened out. There was one pseudoarthrosis in the plated group that required revision. But the one thing that did stand out is that the 2-level cases that had a standalone cage, those patients reported higher levels of pain on several scales. So they felt that plates may lead to a higher short-term stability and improved patient-reported outcomes in 2-level fusions. And this is the device that they use. And dysphagia, still remains a little puzzling because you look at the prominence of that apparatus ventral to the spine. You wonder why it wouldn't have equal amounts of dysphagia. And this is just a quick slide. There have been other studies, like this was a finite element modeling study where they looked at an ACDF cage and a plate, and they looked at a standalone cage that had its own integrated screws, and they found that there is greater stress applied to the end plate and the screws with a zero profile or standalone cage. The stress is more unevenly distributed, and this may explain the higher levels of subsidence with these standalone cages. And then finally, the last paper I'll show you is a meta-analysis. It's a meta-analysis, but it pulled 455 relevant citations, and they found 19 studies that met their inclusion and exclusion criteria. And the results, this pooled data showed that standalone cages had a significantly lower rate of dysphagia and adjacent segment disease. The plate plus cage patients had a significantly less subsidence and better restoration of lordosis. And interestingly, there were no significant differences in several different patient-reported clinical outcome scores. But when you look at their conclusions, you read it carefully, they claim better clinical outcomes, but it was all based on the lower rates of dysphagia. And for the short time they did this follow-up, lower rates of adjacent segment disease. And this is all with equivalent scores in the patient-reported outcomes. So it makes you wonder. The authors also claim lordosis and less subsidence in the plated group probably wasn't really clinically important as what they found in this pooled data. The problems with this study is that, just the topic of dysphagia itself, we don't fully understand it. Is it due to the thickness of a plate? Well, some of these plates now are sub 2 millimeter thickness. Is it a retraction injury to the esophagus at the time of surgery, edema, hematoma? Is it just fibrous adhesions that develop between the esophagus and the plate? And you can go on talking about biologics that are used for fusion. And the limitations of this meta-analysis is there's lots of heterogeneity across studies. Only 5 of these studies were prospective studies. Most were observational in nature, which brings in a lot of potential bias. There were multiple surgeons using multiple materials and methods in the various papers. The analysis of X-ray was often done by the surgeon himself that wrote the paper and not by an independent researcher. And they pulled this data to show that there is a lower incidence of adjacent segment disease, but the follow-up is very short, and in 1 or 2 years, you just may not see that. So the authors at least admitted that more prospective studies with longer follow-up are needed to assess adjacent segment disease. So to conclude, and in this case, my opponent, I agree with him that that's a case you do anteriorly. It's kyphotic, it's multi-level compression at the level of the disc spaces, perfect case for ACDF, but cervical plating remains the gold standard. There's greater immediate stability, it maintains lordosis, it prevents graft or cage extrusion and subsidence, and promotes high fusion rates. And subsidence and loss of lordosis, they may not matter when you read these papers in the short run, but they sure matter in the long run, because we know it leads to adjacent segment degeneration when you have new kyphosis, new collapse in a patient that's already had surgery. And the whole topic of dysphagia is the data seem to show more of it in plating for sure, but it's something we still don't fully understand. So please, for a case like this, in all your regular cases, anything but a standalone cage. Thank you.
You like that?
All right, on to the judgment.
Good. We'll stop right there, Jay.
Yeah, exactly. You got the edge. What was that? What was that hand count on under 40? All right, I think we're going to give it to Dr. Rhodes. Thank you very much.